Welcome back to another episode of MedCity FemFwd. I'm Marissa Plescia, reporter for MedCity News. The American College of Obstetricians and Gynecologists recently issued new clinical guidance around endometriosis. To discuss these changes, we're joined by Dr. Barbara Levy, Chief Medical Officer of Visana Health. Hi, Dr. Levy. Thank you so much for joining MedCity FemFwd.
Thanks for having me. It's a pleasure.
Yeah, absolutely. So maybe just to start, can you just tell me a little bit about yourself and Visana Health?
Sure. I'm an obstetrician gynecologist with more than 4 decades of experience in women's health. I'm Chief Medical Officer for Visana Health. I'm also a clinical professor of OBGYN at George Washington University School of Medicine and UCSD Health. So lots of hats. Visana Health is a 50-state virtual women's health company. So we are able to care for women across all 50 United States for all of their gynecologic conditions. We don't treat pregnancy, and we're not infertility experts. We don't do IVF, but we can certainly help with the fertility journey as well. So it's really holistic care for women.
Great. Thank you so much. And going off of that, the main topic of our conversation today is the new guidelines, clinical guidance around endometriosis from the American College of Obstetricians and Gynecologists. Before we get into the significance of these guidelines, can you just kind of walk us through what some of these guidelines are and why it's important?
So maybe we should start with what endometriosis is. It's an inflammatory condition. It's likely a systemic inflammatory condition that impacts women with lesions inside the pelvis that don't belong there. So, early days, we thought it was that the lining of the uterus, when we had a period, would go out the ends of the tubes and it would implant. And that's still a theory. But essentially, it is an inflammatory systemic condition that can cause infertility. It can cause severe pain with periods. It can cause heavy bleeding. And so, unfortunately, it's present in a lot of women. And what we thought we knew about it 40 years ago when I trained is not entirely accurate for now. So we used to think that the only way to make this diagnosis, because Lord help us, we don't listen to women. So we thought we had to do surgery to see these lesions in the pelvis. And so this new guideline is really wonderful in that it focuses on listening to women and our symptoms and being able to make that diagnosis without having to do surgery on people. So the constellation of symptoms of pain with sex, of pain with periods, of chronic pain throughout the pelvis, not necessarily with the period, but at other times, pain with urination, pain with having a bowel movement. All of those things are red flags for having this inflammatory condition in the pelvis. And what ACOG, the college, has said is that's sufficient to make a diagnosis. So her story of her experience of these symptoms, plus or minus a physical exam, plus or minus imaging, whether that's ultrasound or other things, but you don't need those things to make the diagnosis. It is a clinical diagnosis. And that's so important because it's validating, right? It's saying to women, these symptoms are real, and no, they're not normal. It's not normal to have excruciating pain. And yes, you deserve treatment.
Thank you. Yeah, that's really helpful. And you mentioned that this is a condition that affects a lot of women. Do you have any data on just how many women it affects globally in the US and, what some of the challenges have been that they've faced historically?
Yeah, it's actually about 10% of women. And it's interesting, the founding story of Visana Health is that our male founders, mother, aunt, and grandmother, all suffered with miserable periods for decades and were never offered anything other than surgery for treatment. And so they just suffered. And so the problem is that A, women are not taken all that seriously. B, pain is not something that I, as a physician, can measure. It's something you as a patient experience. And so because we didn't have any objective way to say, well, your pain's worse than somebody else's, we tend to be more dismissive, which is certainly not serving women. So for decades, people have suffered and been told to just tough it out because periods hurt, or because, another surgery is what you need, one more thing to invade your body. And it's been really crazy making. Women feel dismissed. It interferes with their social lives. It interferes with work. It interferes with their sense of themselves. So anybody who has chronic pain gets depressed. I mean, so the whole constellation of things is really disruptive to people. And it doesn't need to be. We need to understand what's happening in her body, how her body's reacting to what's happening, and then be able to intervene in different ways to help her function. I mean, the whole idea is to function. You're not going to die from endometriosis. It's not cancer, but it's every bit as disruptive to people's lives.
Yeah, very well said. And going off of that, now that these guidelines for diagnosing endometriosis has been updated, what does treatment look like for women today now, like after they get that diagnosis?
So there's so many options, and it's important that we offer the whole gamut, right? So everything from an anti-inflammatory diet, people understanding that what they eat can affect how their bodies react to this tissue inside of them, how people sleep. If you don't sleep well, your body doesn't clear, substances from the brain that will affect how you interpret, how your brain feels pain. We can hormonally suppress the lining tissue of the uterus, and that suppresses the tissue that makes these inflammatory substances. So that's an option. We can address the experience of pain itself. When we feel pain, our body has a huge reaction to that because it's trying to protect itself. So we also know that people who have chronic pelvic pain have severe spasm of the muscles in the pelvic floor. And those muscle spasms cause horrible pain. And so by addressing the muscle spasms and teaching people how to relax those muscles when they begin to feel pain can give people power back over their bodies. People feel out of control. They feel like their bodies are punishing them. Their bodies are against them. And so giving people tools, breathing techniques, meditation, it sounds simple. It's not simple. What the brain is wired that when we feel pain, we want to run away from whatever it is that's causing the pain. And so we get afraid and we get depressed. And all of those things have to be addressed if we're going to really improve quality of life, which is the goal.
Yeah, absolutely. And what does Visana's support and treatment look like for women with endometriosis? And how does that compare to the standard of care?
Yeah, I'm not sure there is a standard of care, but if you would look at ACOG's guidelines, it's always to start with non-invasive, low-cost things first. But what we do at Visana, because we're finding people at different stages of their trajectory, right? So if somebody's already tried 15 things and they're frustrated and they're angry and they're, so upset, we will meet them where they are, try to learn, what have you tried? Why didn't it work? Some people feel really depressed on hormones. Some people don't want them for whatever reason. So we try to meet people where they are. We try to listen, right? What do you think is going on? What are you most afraid of? And how can we address that? Because that fear wiring is really powerful. And so people are afraid we've missed some horrible disease or something. And when you feel that much pain, you're sure there's damage going on in your body because that's how you're wired. So we meet people wherever they are. If they're at the early stages, I really like to find people way early if we can, even teenagers who are having maybe just really bad pain with their periods, and nip that in the bud, like right then. We do a lot of education. So the chemicals that the lining of the uterus makes cause inflammation, they cause heavy bleeding, and they cause pain. But that lining is a factory. It makes those chemicals. Most of the medications that we have don't block the action of the chemicals. They stop the factory from producing them. And that means you have to start them a couple of days before bleeding, before the period, or they won't work at all. So many people come to us and they say, well, they told me to take, ibuprofen or naproxen, and it never worked. But they were never educated about how to take it and why you have to start it early. So we work with people. It really depends on what their symptoms are. If the major symptom is pain with sex, that's a different approach potentially than if the major symptom is pain with severe periods.
Yeah, and what's made it so difficult, is the variety of symptoms what has led to it being difficult to diagnose in the past?
Well, I think partly it was that we thought we had to see it with the laparoscope, that we had to do surgery to validate women's experience, which never made sense to me. Like, we don't do surgery to diagnose things. We do surgery when it's the last ditch effort when nothing else has worked. So it's really that women have been dismissed, and our symptoms, because they can't be objectively measured, have just been ignored, or we've been told to tough it out or to expect it, because after all, women have periods, so live with it. And then some people's experience, like it goes in families. So they've seen this, and sometimes people don't even go for help because they expect that they're going to be dismissed. Or they expect that the only thing we're going to offer is birth control pills and they don't want them. So at Visana, the first thing we ask is, what have you tried? And where's your head? What do you want to do? How do you want to approach this? Again, it's not cancer. You're not going to die from it. And so we really want to meet her where she is and work with her. And chronic pain is not something that resolves with an easy button. You don't there's not one magic pill. There's working with people and helping them understand that when they hold their breath, they tense their muscles. So breathing exercises, helping people sleep so that their brains can recover. It's really a multidisciplinary way of approaching it that is done a lot in the chronic pain centers in some of the universities around the country. They've really come to approach it that way, but it isn't the way most OBGYNs are trained. And so women suffer.
Yeah, very well said. Obviously this update in the guidelines is very major news, but what more would you like to see when it comes to endometriosis care? What more needs to be improved?
We need to understand how to stop the inflammation, like root cause. We still don't know the root cause. We know the lesions. We know that there are different types of endometriosis, like there's superficial, which doesn't tend to cause as many symptoms. There's deep infiltrating endometriosis that tends to cause pain with sex, pain with bowel movements. And then there's endometriosis on the ovary, which causes cysts on the ovary. Maybe those are 3 different diseases. I mean, we don't really understand the root cause here. And until you know the root cause, it's pretty hard to come up with the right solutions. So we can deal with the consequences of these lesions that we see, but the research has to, and there's a lot of research going on now for markers, like a biomarker, blood marker, a marker in menstrual blood. And ACOG actually said specifically not to use those right now because they haven't been validated yet and they're not all that helpful. And in my mind, We don't really need them. If we would just listen to women and deal with women's symptoms, that's what's key. And understand that it's way more than just the lining of the uterus. It's what's our diet like? Are we sleeping? Are we exercising? What else is happening that's causing our bodies to react this way? And recognize that pain is a reaction of the body. So it's a lot of pulling all of this together into a whole picture that's really going to help women, I think.
Yeah. Yeah. And can you also talk about what needs to be done from the training perspective of OBGYNs to better treat this condition as well?
Yeah, I think overall doctors need more training in chronic pain generally. So chronic back pain, chronic headaches, TMJ, irritable bowel syndrome, these things overlap a lot. And so I think we need to train doctors about the whole systemic consequences of pain, but also how does pain happen? It's not just that there's an injury to tissue, that the nerves then go through the spinal cord and up to the brain. There are multiple levels of how pain is interpreted by the body, by the brain. And I think we need to train. I know for me, it took me about 6 weeks in practice to figure out that I needed to learn this stuff. I was one of very few women, and I had these women flocking to my practice who'd been dismissed, who'd had multiple surgeries. And I figured out that what I was taught wasn't adequate, wasn't enough. And so I really did a deep dive into pain. Like, what is the experience of pain? How does it happen? What are the nerves? What are the pathways? And it's very complicated. And it gets hardwired into people over time. And that's what the chronic pain is. And that's not adaptive. And so how can we undo those things? That takes a curriculum, I think, in medical school to train people how to approach chronic pain as the disease itself. Pain is the disease.
Yeah, yeah, absolutely. Well said. Well, one last question for you. What precedent do you hope this sets for other women's health conditions outside of endometriosis, like PCOS, for example?
Yeah, I think PCOS, menopause, all these things, we're looking for markers, right? We want the blood test to validate. We want, some hormone test. Just listen to women and your story will tell us what's going on, right? The history, the story is most important to the art of medicine. And validating pictures or histology or blood tests or any of those things tell you a moment in time, but they don't give you the whole story. And so I think the most important thing for women's health in general is listen to us and understand that we actually know our bodies better than the textbook does. Be curious and be humble and recognize that there are a lot of black holes. There's a lot of research that we don't have that we need to drive treatment. And until we have those things, we work with patients, we work with people for what works for their body.
Yeah, that's a great call to action there. Well, Dr. Levy, this has been a very insightful conversation. Thank you so much for joining MedCity FemFwd. Really appreciate it.
It's been my pleasure, Marissa. Thank you for having me.